for this section, I wanted to focus on SARS-CoV-2, just because we all have that recent experience, and is when a lot of different public health measures were implemented. So we guide you through this example to make it more operational and easy to understand. Here on March 2023, not too long ago, the last interim guidance on how to adjust these public health and social measures in the context of COVID were published only 2 years ago. So this is a really good reference to consider when drafting your plan. What COVID showed us is that public health measures were critical. We needed them. We knew that we could develop a vaccine. We didn't know how effective it was going to be and how long it was going to take. Unprecedented development of medical countermeasures, but public health measures were critical. The key objectives were very clear, and as I mentioned before, transmission, mortality, and impact on health systems. And it also showed COVID that we needed to have considerations on how to adjust, because the epidemiological context continued to change, mainly because of immunity levels, as transmission spread, as variants emerge. So that idea that is cyclical and dynamic needs to be embedded in our national preparedness plan for respiratory pathogens. For that pathogen X, we don't know if it's going to be a coronavirus, an influenza, or another type. And also that it needs to be adjusted as data and evidence becomes available. So here's a list of the public health and social measures that were implemented in COVID or that are listed in our guidance at some point. And as you can see, some are interventions that could be implemented within the health sector independently early in the pandemic, early in the stages, and then it will be rolled out to the community as needed. And others really require that whole of government approach immediately, like international travel restrictions is not a decision that the health sector will take eventually. So just to let you know where that final guidance ended up after the experience as we were evolving with the COVID. So first here, there's a recommended matrix for assessing transmissibility, impact on morbidity, and also mortality, and impact on the health system. This might seem familiar to many of you who work in surveillance, because we're talking about the PISA indicators and the parameters. What basically the guidance is mentioning here, and something that you can adapt for your plan, is you need to assess the intensity within of the disease and these different dimensions. And then from that you will have a situational analysis. In this case, it's recommended. It was possible to do it quantitatively. For other pathogens early in the pandemic, we have guidance, and maybe we don't have enough evidence to do this quantitatively, but we can do it qualitatively. The idea is that there's something systematic, transparent, and useful that different geographic areas and different leadership can understand of what we're doing. And all of the situational analysis allowed us to develop levels, and it's level from 0 to 3. For the particular case of SARS-CoV-2, at the time that a lot of immunity had been developed. I have an example of situational level 1, where we have minimal transmission and we have basic ongoing public health social measures needed. So here you can see that we have individual public health social measures. Contact tracing at this point is useful because there's minimal transmission, so we can do supported quarantines. We have considerations for schools. We have considerations for businesses, for domestic movement. So this is just a systematic way to think, okay, at this point, with minimal transmission, we don't need to be at the highest level of alert in all of the sectors. And it's important that we keep that gradual categories also to align with multi-hazard response plans that might be in place, but to make sure that other impact on livelihoods is well calibrated.